I'm going to give you a very brief review of hemodynamics. Here are your objectives related to hemodynamics. Hemodynamics is one of the more complex ideas in the body to understand. Ultimately, hemodynamics is just describing the movement of blood throughout the circulatory system. And this is going to be influenced by the heart's pumping mechanism, as well as properties of the blood vessels and the blood itself. It is going to be affected by principles of blood flow, pressure, and vascular resistance. And this is going to ultimately determine how well tissues are supplied with oxygen and nutrients. So this is one of the driving forces of perfusion. We use both invasive and non-invasive tools in the clinical setting to help us determine a patient's hemodynamic status. And you're probably more familiar with hemodynamic monitoring than you realize. Some non-invasive tools that we utilize can include non-invasive blood pressure cuff. You may see the non-invasive hemodynamic monitoring systems such as the Cheetah, telemetry, EKG monitoring, pulse ox. You may see the Doppler, the point-of-care ultrasound. Even temperature and urine output can give us a clue about a patient's perfusion status. Sometimes a patient's condition will warrant us to utilize invasive hemodynamic monitoring because this can often provide us with a more comprehensive or complete picture of our patient's overall hemodynamic status. Invasive hemodynamic monitoring can provide us with information that we may not be able to get with our non-invasive, such as our pulmonary artery wedge pressure, our pulmonary artery pressure, our central venous pressure. We may use a pulmonary catheter to get these numbers, or we can connect a pressure bag to our central line and get our central venous pressure that way. You may also see arterial monitors used, where we insert an arterial catheter into an artery so that we can see a patient's blood pressure, including their systolic, diastolic, and MAP in real time. This can be very useful when we have a patient who is on multiple vasoactive drugs or inotropes that we need to titrate, or a patient who is very hemodynamically unstable. Here are some terms that you may frequently hear being utilized when discussing hemodynamics and hemodynamic monitoring. Cardiac output. What is cardiac output? It is the volume of blood in liters per minute that is pumped through the heart. And normal cardiac output is 4 to 8 liters per minute. But I want you to think about something. Body surface area, and how that could affect the amount of cardiac output a patient may need in liters per minute. Well, cardiac index is going to account for that body surface area. Let's think about it. An 89-year-old Olympic swimmer, 4 liters of cardiac output may be more than adequate for this patient. Meanwhile, a 475-pound sumo wrestler, 4 liters of cardiac output is probably not going to be adequate to perfuse this patient. So we're going to utilize cardiac index to account for that body surface area. And normal's anywhere about 2.5 to 4 liters. You may also hear stroke volume. Stroke volume is the volume of blood that is pumped out of the left ventricle with every heartbeat. You may have heard of end diastolic volume and end systolic volume. And this is going to just be the amount of blood in the ventricles at the end of dystole for the diastolic, or at the end of systole if we're talking about the systolic volume. So what affects cardiac output? Stroke volume times heart rate, right? That's your calculation, right? But what does that mean? Why? Why? What is that? Your stroke volume is going to be a combination of three factors, which is your preload, or the amount of venous return that is going to return to the right side of your heart, your afterload, or your vascular resistance, and your contractility. So both your preload and your contractility, if you increase that, what do you think is going to happen to your cardiac output? It's going to increase, right? Increase the volume, and your cardiac output is going to increase. Increase the amount of force that the heart is beating. That is also going to increase cardiac output. However, your afterload or systemic vascular resistance is a little different. That's the amount of force that the left ventricle must overcome to pump blood to the rest of the body. And if your afterload is high, that means your heart has to work harder. So the higher your afterload is, the harder your heart has to work. And this is going to lower cardiac output. And the other part of cardiac output besides your stroke volume is going to be your heart rate. Your heart rate is going to increase in order to increase cardiac output. But we have to remember, if the heart rate increases too much, the ventricle is not going to have adequate time to fill, and it's not going to pump adequate amount of blood to the body.
We're going to discuss some terms you may hear when discussing hemodynamic monitoring. First is your MAP. And remember, your MAP needs to be 60 to 65 minimally under everyday circumstances in order to perfuse your kidneys. And your MAP is just your average blood pressure in the arteries during a cardiac cycle, and it is a better indicator of how well blood is flowing to vital organs than the systolic blood pressure. I always look at my patient's MAP unless they are end-stage renal, because they're going to have lower MAPs. Plus, I don't really care if their kidneys are being perfused because they don't work anyways. But another thing is going to be your central venous pressure, and that is just an indicator of that pressure within your right atria. Next, we look at your mixed venous oxygen saturation, and we use this value to titrate inotropes. And it is going to represent the value of oxygen delivery versus oxygen consumption. We will also look at that serum lactate, because lactate is going to be a very good indicator of how well a patient is perfusing, or if they are going into anaerobic metabolism. We also look at that partial pressure of oxygen in the arterial blood. You know that PaO2 on the ABGs? We will also look at things like your right atrial pressure, your pulmonary artery pressures, your pulmonary artery wedge pressures, and this just gives us a very clear picture of the entire hemodynamics of a patient. And we can use both invasive and non-invasive methods to measure some of these. But some of these, like your CVP, we will generally need invasive technology. Now, your CVP, like I said, was your right atrial pressure. That is going to give us a good idea of your right ventricular function and that venous return to the right side of your heart. Now, when your CVP is low, that means you have a low volume. That's usually associated with hypovolemia. When you have a high CVP, I want you to think of hypervolemia, right ventricular dysfunction, a tension pneumothorax, cardiac tamponade. Think about it. You're going to have all of this blood flow trying to return back to that heart with tamponade, but since the heart is unable to pump, it can't go into that atrium, to the ventricle, to the pulmonary system. So you're going to have a high pressure right there at the right side of your heart. Now, pulmonary artery wedge pressure, that is going to be your left atrial pressure. That's going to be the preload of the left side of the heart. And it's going to be increased with left-sided heart failure as well as cardiac tamponade. And just like your CVP, it will be decreased with hypovolemia. Now, your systemic vascular resistance, or your afterload, is going to be that systemic resistance on that left ventricle, what it has to overcome in order to circulate blood to the entire body. Think about it. Things that'll cause increased systemic vascular resistance will be hypertension, because your vessels are going to be clamped down, plus your left ventricle has to have go against the aorta, and when your aortic pressures are high like that, that means your left ventricle is going to have to work so much harder. It will also be very high in cardiogenic and hypovolemic shock in your initial stages because you are trying to compensate. And things like vasopressors are going to cause increased vascular resistance. Now, it's going to be decreased vascular resistance in your sepsis. That's going to be that massive vasodilation, neurogenic shock, any type of distributive shock, or when you're taking medications that cause vasodilation.
Next, I'm going to talk to you very briefly about arterial lines. An arterial line is just an indwelling catheter that allows for direct and continuous monitoring of systolic, diastolic blood pressure and maps. And this is going to provide us also with an easy access for arterial blood sampling for patients who require frequent ABGs. And with an art line, there are various indications, such as frequent titration of vasoactive drips, so patients who have acute decompensated heart failure, patients who have had cardiac surgery, patients who are very hypotensive or hemodynamically unstable, and in patients where there are so many issues going on that we are unable to get an accurate non-invasive blood pressure. And most of the time, the arterial line is going to be placed in either the radial or the femoral artery. However, you can see it utilized in the brachial as well as the dorsalis pedis artery. We know that the radial site is one of the most common sites for arterial line insertion, and prior to inserting a arterial line into that radial artery, a modified Allen's test should be performed. And this is just going to assess the blood flow through both the radial and ulnar arteries by occluding both of the vessels and then releasing pressure from one to observe the capillary refill of the other. And this is just going to test the artery's patency and let us know if there is adequate collateral flow from that radial artery to that ulnar artery. Because think about it, when we place that arterial line, there's going to be a catheter that is going to be placed into that radial artery that is going to be partially occluding the vessel. And a patient may have pre-existing conditions such as peripheral artery disease that could cause severe ischemia to occur if we were to place that arterial line in that radial artery. So this is just a way to kind of help us see, is the patient going to be able to perfuse their hand, the rest of that arm, if we place this catheter. And with this, you want to look for a positive test, and that is normal. And that is if the hand flushes pink within 5 to 15 seconds and is going to indicate that there is good collateral blood flow from the radial artery through the palmar arch. And a negative Allen's test is bad. And if the hand remains pale or the color returns significantly delayed, like that cat refill is super delayed, then it's going to suggest that there's inadequate collateral circulation via that radial artery, and maybe a different site should be chosen because there could be dire consequences such as limb ischemia, and ultimately necrosis could occur, causing a patient to need an amputation. You will notice that an arterial line setup has various parts, including that arterial catheter, which is going to be placed into the artery, and it's going to be connected to a pressure tubing, and that pressure is going to come from a pressure bag that is going to be inflated and maintained at 300 millimeters of mercury pressure to prevent that backflow of blood out of the artery and to maintain that negative pressure. And you're also going to see that that tubing is going to be connected to a transducer, which is going to convert the patient's arterial blood pressure into an electrical signal. And we're going to connect it to our monitor via a cable to allow us to see a waveform and assess the arterial pressure number. You will notice that the pressure bag is going to contain normal saline. And this is going to allow for us to flush the line, to prevent clots, to ensure the patency of that catheter. And that transducer is going to be leveled at the phlevostatic axis, which is the fourth intercostal space mid-axillary line, which is going to provide us with the most accurate determination of a patient's arterial blood pressure. Nursing considerations related to arterial lines are going to be related to maintaining aseptic technique when accessing that system or obtaining a blood sample, because this is a closed, sterile system. You want to ensure that your dressing is clean, secure, dry, and intact. You want to look at the site, the catheter. Is the catheter secure? What does the site look like? Is it reddened, inflamed? Does it look infected? Is there signs of a hematoma formation? Is it draining or is it bleeding? And it's also important that if you are working with arterial lines that you understand what the waveform should and shouldn't look like. For example, if a waveform is over dampened, this will give us an artificially high blood pressure. Or if a waveform is underdampened, it can give us an artificially low blood pressure. And also, let's think about this. Let's say we've had a beautiful arterial line waveform on our monitor all day and suddenly it disappears. It could mean a few things. It could mean your system's no longer working. It could mean that someone is currently accessing your system, such as the RT to get a ABG, and you can't transduce the blood pressure and access the system at the same time, so maybe that's it. Or it can mean your patient's in cardiac arrest. They're not going to have a waveform if they're dead, right? There's no pulsating blood flow there. It could also mean that your catheter is dislodged. And remember, this is in an artery. And many of your patients who require an arterial line are going to be on anticoagulants, antiplatelets. They may have coagulopathies going on, and they can bleed out very, very fast. So sudden cessation of an arterial waveform needs to get your urgent attention and go assess. And ultimately, the blood pressure reading with an arterial line should be pretty consistent with the non-invasive blood pressure. But ultimately, your arterial line blood pressure should be more accurate. Now, if your non-invasive blood pressure and your arterial line are reading very different, you want to make sure that your arterial line system is leveled. You might want to re-level it, re-zero it. Is that waveform appropriate? And if it is, that's what you should go with. And ultimately, always assess the patient, not the monitor. Look at your patient. And you want to monitor for limb ischemia. You want to look for signs such as a cool extremity, a lack of blood flow. You want to look for that capillary refill. Do you have a pulse? Because if you are showing signs of limb ischemia, that arterial line needs to be removed immediately, or you could be missing part of a limb. And you want to continue to just monitor the site, the patient, and everything.
Next, I'm going to talk to you very briefly about pulmonary artery catheters. And pulmonary artery catheters are invasive catheters that are going to be placed in the pulmonary artery. You may hear a Swan's catheter. That is a very common type of pulmonary artery catheter. So these pulmonary artery catheters are going to be inserted through a central vein, such as the FEM, the IJ, and then they're going to be advanced into the pulmonary artery. And they are going to have a balloon that can be inflated or deflated to check certain pressures within that pulmonary artery. And we can get a variety of different measurements from these pulmonary artery catheters, such as your CVP, your pulmonary artery pressures, the pulmonary artery wedge pressures. And this is going to give us a very accurate idea of a patient's hemodynamic status. Next, I want you to look at the different lumens of the pulmonary artery catheter. Each of these lumens are going to give us certain measurements to help us get an overall hemodynamic assessment for the patient. The pulmonary artery catheter gives both direct and indirect measurements, which provides us with a clear picture of the entire heart, both the right side, the pulmonary function, as well as that left side of the heart. And it's going to be indicated in very critically ill patients, such as those with severe ARDS and sepsis, post-operative CABG patients that require inotropic therapy, or we just need to monitor their hemodynamics closely. For patients in cardiogenic shock, for those with severe trauma and burn injuries. And that is it.